Good afternoon, everyone, and welcome to today's webinar on the use of long axial field of view and total body PET imaging in the clinical area of cardiovascular disease. My name is Dr. William Drew, and I am the National PET Imaging Platform's PET Engagement and Delivery Manager. Long axial field of view and total body PET systems offer transformative capabilities, dramatically increased sensitivity, lower administered doses, and the ability to capture whole body dynamic biological processes. These features create new opportunities to safely study human physiology and disease in ways that were previously not feasible. NPIP, the National Total Body PET Imaging Platform, is working to promote and support the application of next-generation PET technologies to clinical and therapeutic research. We're delighted to be joined today by two leading clinicians and researchers who are at the forefront of applying these technologies in cardiovascular disease. Our presentation today will be delivered by Professor David Newby of the University of Edinburgh. Professor Newby's presentation is titled Non-invasive in vivo thrombus imaging in cardiovascular disease. Professor Newby is British Heart Foundation Duke of Edinburgh Chair of Cardiology at the University of Edinburgh and a consultant interventional cardiologist at the Royal Infirmary of Edinburgh. He is Director of the Institute for Neuroscience and Cardiovascular Research, the British Heart Foundation Centre of Research Excellence, and Edinburgh Imaging Facilities. Professor Newby's research interests are in experimental medicine, advanced imaging, and clinical trials of cardiovascular disease. These research interests led to Professor Newby acting as the chief investigator for several high-profile, multi-centre clinical trials, including the SCOT-HEART and the SCOT-HEART-2 trials, which evaluated the role of CT coronary angiography in diagnosing and preventing heart disease. Following Professor Newby's presentation, we will be joined by Dr. Jason Tarkin of the University of Cambridge for some reflective discussion and the audience Q&A. Dr. Tarkin is a Wellcome Clinical Research Career Development Fellow, Associate Research Professor at the Heart and Lung Research Institute of the University of Cambridge, and an Honorary Consultant Cardiologist with an imaging subspeciality at Cambridge University Hospital's NHS Trust. Dr. Tarkin is the Treasurer of the British Society of Cardiovascular Imaging, the PET-CT co-lead for the MRC British Heart Foundation UK Cardio IMID Network Steering Committee, and a member of the British Atherosclerosis Society Executive Committee and the British Cardiovascular Society Ischemic Heart Disease Working Group. Dr. Tarkin has recently been awarded a British Heart Foundation Senior Clinical Research Fellowship to conduct an experimental medicine study focused on interleukin-6 signalling in atherosclerosis using total body PET. We're very pleased to have you join us today, and we look forward to a stimulating presentation and discussion. Before I hand over to Professor Newby, I'd like to remind you to please post any questions that you may have in the Q&A box at the bottom of your screen. We will try to address as many of these questions as possible during the presentation. I'd like to hand over now to Professor Newby.
Thanks very much, and thank you for inviting me to give this seminar today. So what I'm going to do is to share with you our experience of using thrombus imaging in cardiovascular disease, with a particular focus on myocardial infarction and stroke. So these are my disclosures. The one really to highlight is the life molecular imaging provided the tracer I'm going to talk about, which is called GP1. And Fusion Quant is a company that produces software that we've used in this presentation. So what I want to do is to really step through the work that we've done looking at thrombus imaging in cardiovascular disease. And I want to start off by talking about the validation before describing some work on myocardial infarction and stroke. And if I've got time at the end, I'll also talk about some interesting findings we've had with cardiovascular prostheses. So validation, first of all. So when we think about thrombus imaging, there are various different ways that we can see thrombus in the body, but most of them are pretty indirect. So it's usually a filling defect on an angiogram. It's sometimes a mass that we see on ultrasound that we're not quite sure about. And we can use intravascular techniques to try and look at it in even greater detail. But all of these things make the presumption that this is a thrombus, which is often circumstantial. So we need a technique that can potentially identify thrombus with specificity and accuracy. And this is what the tracer 18F-GP1 does. GP1 is derived from a glycoprotein 2B3A receptor antagonist called LRFibin. This tracer, or this molecule, should I say, binds to not only the receptor on platelets that causes platelet aggregation when it combines with fibrin, but it also only binds to that glycoprotein 2B3A receptor when it's activated, so when it's in its activated state. And these are some preliminary data that we did using ex vivo platelet studies. Now, when you concentrate platelets ex vivo, you always end up activating them a little bit, so you can never get away with that. But what we did was take platelet-rich plasma, and then in one sample, we added ADP, a potent stimulus for platelet aggregation. And you can see in the bottom right-hand panel there that GP1 binds much more avidly to activated platelets rather than the platelet-rich plasma that we generated. So demonstrating some specificity here for activated platelets. We've gone on to try and look at this and validate it further. On the left-hand side there, you can see a very happy volunteer who has some blood drawn across 3 chambers. This is a model of deep arterial injury where non-anticoagulated blood is passed through some chambers, and in the floor of the chamber, there's a denuded pig aortic strip, which is a thrombogenic surface, so a clot forms in flowing blood. And we do that for 5 minutes and then fix the tissue to have a look at the thrombus on it. Now, in the upper panel in the center of the screen there, you can see that there's a stripe there of GP1 binding, which is the channel of the chamber as it sits on top of this pig aortic strip. And you can see that it binds with high avidity to it. The slide adjacent to it is tyrofibin, which is another glycoprotein 2B3A receptor antagonist, but this is given in high quantities. And we're infusing these things just upstream of the chamber, outside the body, but just upstream of the chamber. So you can see it seems to be very specific for it. And then you've got the histology on the right-hand side, where you can see the H&E staining and also the CD41 immunohistochemistry, CD41 being the glycoprotein receptor. On the bottom of the slide there, you can see some specimens of thrombectomy. So these are samples aspirated out of a coronary artery in someone that presents with an STA segment elevation myocardial infarction. And again, you can see that the GP1 binds with great avidity to the thrombus, and we can block it with GP1. And again, the immunohistochemistry showing that this mass is predominantly made up of activated platelets, which we're seeing lighting up. So giving us some validation that this tracer is very specific to thrombus. Now, when we start to use this tracer, of course, the COVID pandemic hit. So the only thing we could study was COVID-19 with the thrombus tracer. But of course, COVID-19 had a lot of cardiovascular thrombotic consequences. And as you can see, we're able to see pulmonary emboli associated with COVID lighting up. We also saw areas of damage and the fibrosis that goes on and the thrombosis that goes on in the microvasculature of the lungs in this very nasty pneumonitis picture. And you can see that we could detect thrombus within the microcirculation of the lung. And indeed, you can see in the top right autoradiography in a patient that died from COVID. And you can see that the area of microvascular thrombosis and obstruction in the lung lights up beautifully on autoradiography with the GP1 tracer. So again, some validation. So we've got a tracer that binds specifically to platelets that is present in thrombus and in the classic pulmonary embolism lights it up nicely. We also noticed in passing that some of the cardiovascular structures also lit up with thrombus. So top left there, or on the left-hand side, you can see a saphenous vein graft which had become occluded with thrombus, a thrombus in the apex of the ventricle, and also a magnetic resonance PET image showing thrombus in a peripheral artery. So we were able to see throughout the body evidence of thrombosis in these patients. So having validated that, we applied this, first of all, to acute myocardial infarction. This is work that Evangelos Zerlos did with us some years ago, 2 or 3 years ago now, where we took patients who had an acute myocardial infarction. You can see on the invasive angiogram on the left, the right coronary artery, you can see just around the bend there, there's a filling defect. And it's not entirely clear what is going on, but this patient presented with an inferior ST elevation MI. They decided not to stent it there and then because they were worried about the sluggish flow and to give quite a lot of anticoagulants to try and before bringing the patient back for definitive treatment. That gives us an opportunity to do a CT PET scan. And as you can see in the middle panels, the CT angiogram, which shows the right coronary artery in cross-section in the left upper panel, and then the longitudinal view below, the sagittal view alongside. And you can see there's a lot of hypoattenuation. Is that plaque? Is that thrombus? Well, the PET image is fused on the right-hand side, and you can see there's an awful lot of clot sitting in that coronary artery. So Evangelos went on to study around 50 patients with myocardial infarction. A nice example again on the left-hand side. This person, as you can see in the stack of the invasive angiograms in the 3 coronary arteries, the right, the left anterior descending circumflex artery, there's a lot of disease in there, a lot of atheroma, a lot of plaque. The patient presented with inferior ECG changes, and the right coronary artery is the only artery to really light up with the tracer, showing that we could identify the culprit plaque that caused the myocardial infarction in this patient with a non-ST elevation MI. The other plaque, in the non-culprit plaque, did not light up. And you can see, and this is graphically represented on the right, the blue is the patients that had a culprit vessel ascribed with thrombus being identified with GP1. In the middle panel, the same patient, but in the non-culprit vessels, so the adjacent vessels. And then on the far left, on the right, in the red, is patients who didn't present with myocardial infarction, but had evidence of coronary disease, so stable coronary disease, if you like, and again, didn't light up. So this tracer certainly was very specific. Occasionally, we did not see evidence of thrombosis, and there's about 20% of people did not have GP1 uptake in their culprit vessel. 2 explanations for that. One, the length of time to do it. We found that most of the people, when they were imaged beyond 7 to 14 days, the likelihood of having thrombus was less likely. Not completely lost, though. Still, some people showed expression for quite some time afterwards. And it also begs the question whether all myocardial infarctions are due to thrombus or thrombotic occlusion. And we have these type 1, type 2 MI conversations in the cardiology world. So some quite nice data. How does that help us? Well, this was a nice example of a patient where management was changed by the GP1. You can see the movie on the left. This is a patient who presented with an inferior ST segment elevation myocardial infarction. And you can see that the artery was treated and opened and actually ultimately stented because to make sure that flow was properly restored, because there was a bit of a filling defect, as you can see in the still images, A and B, just adjacent to it. This patient, the following day after they'd had their artery stented, came for a GP1 scan, and you can see in the middle CT coronary angiogram the stent in the circumflex with the red arrow at the top there. And then adjacent to that with the green arrow on the right-hand side, you can see thrombus detected by GP1, which is trapped essentially behind the stent. What we weren't quite expecting was the bottom panels. So the left atrial appendage with the red arrow at the bottom there in the middle, you can see a slight filling defect on the CT scan. And when we did the GP1 tracer, it lit up, suggesting that this patient actually had a thrombus embolizing down their coronary artery. And indeed, the patient had had episodes of paroxysmal atrial fibrillation after the heart on the coronary care unit, after the angioplasty. And we think that this actually was not a standard plaque rupture, but actually was paroxysmal atrial fibrillation with a thrombus that goes down the coronary artery. And the patient was therefore started on a formal anticoagulation with a direct orally anticoagulant in addition to the antiplatelet therapy. So it changed the management, changed the diagnosis. So quite a nice example. Now, of course, the coronary arteries are not the only things that get affected with clot when you have a heart attack, myocardial infarction. This is actually a PET-MR study, but what you can see in this person who had a large anterior infarction is you can see the late gadolinium enhancement in the apex of the heart in the top left here, and also in the bottom left. You can also see areas of late gadolinium enhancement, but there are black areas within it, which is diagnosed as microvascular obstruction. And what you can see with the PET image is these areas of microvascular obstruction light up with the thrombus tracer. Now, this is a well-described phenomenon, microvascular obstruction. There are various theories as to what causes it, but certainly the GP1 data suggests this is predominantly due to thrombotic occlusion of the microvasculature, so embolization of the clot down the coronary artery into the microvascular of the myocardium, or indeed in situ thrombosis within an infarcted segment. But these areas are clearly related to platelet activation and thrombus formation. The other thrombus formation that clinically is perhaps more problematic is left ventricular thrombus. So here you can see in the movie with the cardiac MRI, there's an apical infarct, so there's no contraction at the apex. This person had an apical, anteroapical MI, and you can see a filling defect there on the MRI. The still image in the center there really shows that for you, and on the right-hand side, you can see that the thrombus, this filling defect, does indeed light up with GP1, so you're able to identify left ventricular thrombi. So that work led us to do a study called MYOTHROMBUS. This was mostly led by Craig Bamforth, where we took patients who had an acute anterior ST segment elevation myocardial infarction, and we wanted to see what the true incidence of left ventricular thrombus was. And each patient got an echo. They got a hybrid PET-MR and also an MR of their brain. And we wanted to use these data to explore the true incidence of left ventricular thrombus after myocardial infarction, and also to investigate how many of these patients had a clinical stroke or even a subclinical stroke from these left ventricular thrombi. So Craig recruited, with some support from Evangelos, 100 patients, all of whom underwent angioplasty, all of whom had significant LV impairment afterwards, a range of spectrum of left ventricular impairment, all on established contemporary medical practice and secondary prevention, and the usual risk factors for people who have a heart attack. And here's some examples. So this is a patient who had an anteroapical infarct. You can see the echocardiogram top left and the MRI cine bottom left. In the central panels, you can see the late gadolinium enhancement at the apex, the white appearance occurring here around the apex. And this is the PET study. There was no apparent uptake. And these are the corresponding brain images, MRI at the top, PET MRI at the bottom, and no evidence of any stroke. So someone who had an anterior infarct had no evidence of left ventricular thrombus and no evidence of stroke. This is the other end of the spectrum. So you can see here a very similar pattern, arguably, another anteroapical infarct. The echo, you can see there's a thrombus sitting in the apex, same occurring in the magnetic resonance scan bottom left. In the central images, you can see the late gadolinium enhancement in the apex and the blob of thrombus in the apex, and that blob lighting up quite nicely with the tracer, GP1, showing that this is an intraventricular thrombus. And then the brain scan showing an occipital infarct on the MRI, which also lights up with the tracer, GP1. And again, that's due to some microvascular obstruction potentially in that infarcted area of the brain. This example is where we don't see thrombus on the echo, we don't see thrombus on the MRI, but we are seeing some thrombus on the PET imaging. And indeed, this person also had an occipital, a cerebellar infarct, which was seen on the MRI and again lit up with the tracer. So this was quite a nice example of where standard technologies are not seeing the thrombus, but we are seeing it here. And actually, when we compared the different tracers, You can see that the incidence of thrombosis varied between echo, MRI, and PET. Echo didn't see very much, much more seen on MRI, and yet further on the GP1 tracer, demonstrating that it's much more sensitive in picking these things up. And all the MRI positive and all the echo positives thrombi lit up with the GP1. When we looked at how many patients had a stroke, there was only 2 patients that had a clinically apparent stroke. But when we looked on the MRI scan, there were many patients who had evidence of cerebral infarction on brain MRI, but no clinical symptoms associated with that. And often it was a multi-territory pattern, as you can see on the second panel there. There was a lot of people, 12 people who had multi-territory infarcts. And the PET study really, if you were PET positive with GP1 in the left ventricular cavity, your relative risk for a stroke was nearly 10-fold higher. So this is not an artifact. This is a real thrombus that's sitting in the ventricle, which we're underappreciating. And the PET is picking them up, and these subclinical strokes and clinical strokes associated with them. We can also obviously track with time to see whether the thrombus resolves with anticoagulation, and this is a nice example of someone whose thrombus did shrink. Many of the cases they shrank and disappeared completely, but here you can see still some persistent uptake with apixaban treatment that's perhaps not that apparent on MRI, but is still apparent up to 2 years later on treatment. So these thrombuses are dissolving, getting lower, but they don't always completely disappear. This is an example of a condition called Takotsubo cardiomyopathy, which is perhaps a little bit, it is often misdiagnosed as a heart attack, but this condition also has a higher incidence of stroke, and we have had one case here, which we did was supposedly a control patient, but actually had some thrombus in their left ventricular cavity, and as I say, they also have an association with stroke, which is an interesting passing comment on this as well. So that's myocardial infarction, looking at the coronaries, looking in the myocardium, and looking in the left ventricular cavity and its association with complications of myocardial infarction. I want to turn to stroke. So stroke, we did a nice study with Beth Whittington, and we called this the Thrombectomy study. But essentially, we took 100 patients with stroke and looked at whether GP1 could help us identify the cause of stroke. Now, stroke, in general, a quarter of them are felt to be due to carotid disease, 20 cardioembolic, so atrial fibrillation, 15% small artery occlusion. Then there's some smaller niche causes like PFOs. But there's a large number, over a third of people are you're not actually sure what caused the stroke, which is interesting. So Beth started out doing a pilot study to begin with. We did this in people who were being considered for carotid surgery and with a stroke. And what you can see here in the middle panels is the carotid angiograms, and you can see the red culprit vessel and the green non-culprit vessel labeled here. And actually the non-culprit vessel in some ways looks rather worse than the culprit, if I'm honest. But you can see below on the PET study, the fused PET study, that the culprit one lights up quite nicely with the GP1 tracer, and you see further images to the right-hand side in different planes. And when you look to the brain on the left, you can see evidence of cortical infarction there, again with the trace lighting up, and it's lighting up the same side as the carotid artery is. And when we've done some histology, both on the carotid on the right-hand side, but also on some brain tissue from people who died from strokes, we can find evidence of the thrombus tracer on histology, which co-localizes with the autoradiography. And we can block that with non-labeled GP1 to show it's very specific for the actual clot. So some nice histological validation in both the brain and in the carotid arteries. So getting back to the main Thrombectomy study, 100 patients, they all went through assessment, lots of ECG tracings to look for AF, bubble echo to look for intracardiac sources of thrombus, all the clinical information, and a stroke panel determined what the cause of stroke was. All patients also had in series a total body PET CT scanner, and at the end of the classification by the stroke panel, we showed them the data and asked them whether they would have changed their diagnosis or the cause of their stroke on the basis of what they saw. So these are the baseline characteristics. Just under a quarter had a lacuna stroke, so slightly higher representation of lacuna stroke here. That's the small vessel disease stroke. Cortical stroke, 49%, posterior 28%. As you'd expect, the usual cardiovascular risk factors, and they were all on best medical therapy. And some of them had thrombolysis and even thrombectomy, which I'll show you shortly. So here's just more examples of carotid disease. As you can see with the yellow arrow, there is some uptake in the very calcified carotid, and then the cross-sectional images in the middle section showing a stenosis, soft plaque, and some thrombus detected by GP1, and then the right, the brain imaging showing the area of infarction that also again lights up with the GP1 because of this microvascular obstruction and petechial hemorrhage that we get in the brain infarct. Here's another example, but I want to highlight to you here that the carotid stenosis is barely visible, so I don't know if you can appreciate that, but on where the red arrow is pointing on the upper top left, there's a very small plaque there, which lights up, as you can see, bottom left with the thrombus tracer. At higher power in the middle panel, you can appreciate here, hopefully, that there is very little in the way of stenosis coming off here at the junction, the bifurcation of the carotid. There's an awful lot of thrombus tracer up here. So this person had a very big stroke, as you can see on the right-hand side, again lighting up with the tracer. But this stenosis was below current levels that you would consider for surgery. This is a small plaque, and actually it turns out most strokes from carotid disease occur on smaller plaques. It's not the 70% and greater stenosis that most strokes come off. We have taken some carotid endarterectomy specimens to make sure there are clot on what the stenosis that we have seen on the PET CT scans, just to validate again that this is really clot. And when we look across the range of carotid stenosis, you can see that the more stenosis you have, the more likely you are to have PET uptake in general. But actually, the less than the 30 to sort of 50% stenosis is the vast majority of patients, and there's quite a high incidence of clot in there, and that has led us to have some thoughts about maybe studying endarterectomy trials in people who've got clot on their carotid, even when the stenosis is below the standard thresholds for surgery. And corollary of that is that sometimes when it's over 70%, there's no clot, and do you really need to chop it out and put them at the risk of perioperative surgery? So that's one of the ideas that we're currently thinking through. There are other things that we see, particularly on the total body PET, and patients with stroke often have a lot of comorbidity. So this is just on the right-hand side, a lovely example of someone who had a stroke, who's got widespread vascular disease. And not only, as you can see in the spinning movie, did they have clot on their carotid and their brain infarct, but they also lit up their iliac arteries and their femoral arteries. So, and this was silent rupture that was occurring in the atherosclerosis of their legs and lower limbs. So that's something that we're seeing quite a lot. On the left-hand side, there's a different patient who had a stroke, and we went back and asked them about claudication, because as you can see, the CT angiogram of their distal aorta was occluded, and there was a lot of clot overlying that, and they indeed had a long-standing history of claudication, especially in the right leg, which is mostly occluded there. So we do see a lot of other things going on in the body of patients with strokes, and particularly in the arterial circulation, and it's not just the carotids that are causing problems. So, oops, sorry, the movies are taking a little bit of time to work through. So this patient is another cause who also had a stroke, but a slightly rarer cause of endocarditis. What you can see here is that at the top, you've got the infarct lighting up, multi-territory infarct. You can see the aortic valve, which had the endocarditis that was shown on the echo. They also had a digital infarct, and you can see the digit lighting up nicely with the tracer. and had also been in bed quite a long time, so you could see their deep vein thrombosis. They also had a long PICC line from their elbow up to the heart up to the SVC to give them long-term antibiotics, and you can see that actual line also shows some thrombus around it that is visible. So you really do get a lovely pan body picture of thrombosis with this tracer. So this patient had a middle cerebral artery infarct, was rapidly diagnosed and went for thrombectomy. And you can see the thrombectomy here with the reperfusion of their middle cerebral artery after intervention. And this is the PET CT study that they had after they'd had the thrombectomy, obviously. And what you can see on the left-hand side is the origin of that thrombus. So it was from a left atrial appendage. You can see it in two separate views here, which had obviously embolized. And on the right-hand side, you can see on the bottom right panel, the area of stroke. And actually, the adjacent slice, you can actually see where the thrombectomy site was. And obviously, they removed most of the thrombus, but you could still see some residual thrombus in that middle cerebral artery. We've also been able to identify quite a few cardioembolic strokes that have arisen from valves, not in the context of endocarditis, but in the context of subclinical disease. So this patient, as you can probably see on the top panel, and certainly in the middle second panel here, they've got a bicuspid aortic valve, which is thickened, and there was thrombus sitting on that, and that had embolized and given a stroke. So this was an undiagnosed cardioembolic stroke that this patient had. And throughout the 100 series, we've actually seen 11 cases of native valve uptake of GP1, both the aortic valve, sometimes with aortic stenosis, sometimes just a minor thickening, or sometimes on the mitral valve where there's some valve thickening and associated with stroke. So we think actually valvular cardiothromboembolism is probably underdiagnosed in a lot of stroke patients. And then we get to PFOs, and this was a nice case of a lady who had broken her fibula and got a DVT, and then 2 or 3 weeks later had a stroke. And we can see on the rather grainy CT scan that she does have a PFO, and that the occipital stroke that she had again lights up with a GP1 tracer. So nice example of identifying paradoxical embolism. This is another example, which is in many ways more interesting. They didn't have a DVT known about, but they did have GP1 uptake in one of their pelvic veins, which we could identify. We saw a small PFO, but actually it still lit up with a GP1 tracer. So this was almost thrombus in situ, in transit across the little bit of being caught in the patent foramen ovale. And of course, they had a proven stroke. This person was scheduled for a PFO closure device, but actually had a second stroke prior to them having it. And I do wonder whether that little clot finally embolized off again and gave them a further stroke. So overall, this is what we found. Most strokes, 81% of them would light up to a degree with GP1 because of the particular hemorrhage and the microvascular obstruction that we see. Outside of the brain, we see a lot of uptake in areas that perhaps hadn't really considered before, and a lot more in the carotids than have been appreciated. Some in native valves that we really hadn't appreciated, and it's nice to track down some PFOs. But when we look at the whole population, around 1 in 4 people were actually reclassified etiology of their stroke, and particularly that was predominantly seen in those with an undetermined cause of stroke, the area that obviously we're most keen to try and identify the cause of stroke. And finally, what was quite impressive was when we followed these people up, and remember 60% of them had uptake outside of the brain. In that 60% were much more likely to have a recurrent stroke. So the blue is the PET, those that had PET uptake in the cardiovascular system, whereas the pink and the red is those that didn't have it in the cardiovascular system. And it's quite clear that that's where the high-risk people are. They're much more likely to have a recurrent stroke. So in the last few minutes, I'm just going to quickly share some data with you on cardiovascular prostheses, which I think is also interesting. We looked at some bioprosthetic valves that were stuck in that were implanted in the aortic position. There's a lot of evidence that TAVI procedures are associated with clot if they're not put in properly. And we thought this would be a great opportunity to look at this. And with Stephanie Sellers in University of British Columbia, we looked at some explanted, degenerated valves from surgical and TAVI procedures, so surgical bioprostheses and TAVI bioprostheses. And you can see some of the histology here that thrombus does seem to be seen on a lot of these, and actually they do indeed light up very nicely with GP1, which you can block. And it's specific for thrombus. The images at the bottom were areas of fibrosis. There's no uptake at all. Now this is an ex vivo, well, in vivo coronary aortogram on the left, but the ex vivo CT and PET CT in a patient that had a mechanical valve that thrombosed off. And you can see quite nicely that it lights up beautifully with the tracer. When we started to look at bioprosthetic valves and we compared them to normal native valves, we did see quite a lot of uptake of the GP1, as you can see on the right-hand side. So left-hand side, normal valve, right-hand side, surgical valve replacement. And you can see it tends to follow, the GP1 tends to follow the commissures of the prosthetic valve. And of course, that's the area that's constantly opening and closing and bashing together. And maybe that just cannot endothelialize because it's artificial material that's perhaps harder than the native valves, and it becomes de-endothelialized, and the tracer then binds to it, or the platelets bind to it, and then the tracer binds to the platelets. We had thought that bioprosthetic valves would only light up if there was thrombus that we'd seen in the TAVI studies, but actually all the bioprosthetic valves lit up pretty much to a degree, mostly along the commissures. On the right-hand side, you can see the uptake by time of valve replacement, and certainly the uptake is higher immediately after implantation, and it does tail off with years, but nevertheless, it always seems to be up a little bit. The red dots on here are people who had known valve obstruction or valve dysfunction with HALT, so hyperattenuation leaflet thickening, that you could see on the CT angiogram itself. So these people had evidence of clot, and as you can see, they seem to be up the upper end of where it's at. And we did find 3 or 4 cases of people who had bioprosthetic thrombosis that was causing obstruction, and we followed them up. So you can see on the left-hand side a nice example of HALT on the CT angiogram, lighting up beautifully with the tracer. And then after a Pixiban, it doesn't go away completely, but it's certainly markedly reduced, and you can track the ebbs and flow of the thrombus. What we also finally saw was that it didn't really matter whether it was an aortic valve or any other prosthetic material. Most prosthetic material, when implanted, certainly seemed to take up the tracer. And you can see on the left-hand panel here is an aortic Dacron graft that was implanted into a patient who had an aneurysm, as well as their aortic valve, which was a bioprosthetic valve. And you can see that that lights up. On the right-hand side, there's a TAVI valve that's been implanted that's lighting up, but also this patient had an unfortunate episode in the cath lab where a stent was trapped, a guide wire was trapped behind a stent. And when we imaged that, that also lit up with the tracer. That wire had been in there for 5 years, believe it or not, with no consequences. But we do know that foreign bodies in the coronary arteries often lead to myocardial infarction, and it really did light up dramatically with the tracer. So bioprostheses and prostheses in general, pacing-wise, also light up. These are areas that get thrombus, and I do wonder whether that's why a lot of these things get endocarditis when they become infected. Anyway, I've taken you through the validation of the tracer, talked about myocardial infarction and stroke, and give you some insights into how prosthetic materials behave in the vasculature. And I'd be very happy to take any questions about that. Thank you.
Thank you, Professor Newby, for an excellent insight and an excellent presentation. Thank you. Welcome, Dr. Tarkin, to the conversation. So, Dr. Tarkin, I don't know if you have any questions or reflections maybe for Professor Newby, or items you'd like to share with the audience today.
Great. Well, thank you so much, Professor Newby. What a fantastic talk. Wow. I mean, talk about a huge program of research, really exciting tracer, really wonderful example of, how you can use a molecular imaging probe across a spectrum of diseases and really learn about a range of cardiovascular diseases. I mean, you showed us how important thrombosis is in so many of the most common diseases, and real clinical applications. A fantastic range of them, and thank you. I guess my question is, we're sitting here in the NPIP webinar, where everyone has an interest in these new total body PET scanners. You showed us some fantastic images in endocarditis, in stroke. My main question is, to begin with, where do you see the biggest clinical application and the biggest clinical use for a total body PET in this disease, bearing in mind that often it's a regional, thrombosis, it's a stroke, it's a coronary artery, and we're not really interested in the whole body, but clearly there are some applications, and I'm wondering where you see the biggest impact here from the total body imaging.
Yeah, thanks, Jason. And I think what I've shown you some really nice examples of, some of which we already knew, right? But some of it we didn't. And I think it's really fascinating that in myocardial infarction, you get a lot of clot in ventricles that we don't even think about. And the clinical consequence, well, they've not had a stroke, but somebody that has a subclinical stroke is more likely to get dementia and have further problems. The other thing, which I didn't mention too much, is we did do some follow-up scans, and actually those strokes on treatment didn't get any worse, and we didn't see any new strokes. And so the high risk period is actually in the early phase of the myocardial infarction, and we were imaging people 7 to 14 days after their MI. So there is an argument that we are missing clots in the ventricle early. And actually, we did some modeling, and we saw that those that had persistent ST elevation on the ECG and a low ejection fraction are the ones that tended to get most of the tracer uptake. So that insight then leads to, well, if you've got persistent ST elevation infarct and you've got a low ejection fraction, should you be anticoagulating irrespective of a stroke? And I think that is a real important question, and I think we could do clinical trials. Now, that's not using the PET directly, but it's understanding that process, enabling us to then make a better way of managing people. So that's one way I see it going. Another thing I think is stroke, because I was, as cardiologists, we're actually quite blessed. We have the ECG that's really powerful. We do a lot of angiograms. We can get to the bottom of the disease quite quickly and make a decision. And actually, we've only got one major cause. Did show you with the embolus, but it's predominantly about plaque rupture in a coronary artery. Whereas stroke, historically, it's been 25% only. And a lot of stroke, we don't really know what the cause is, and we make associations. So one thing I didn't talk about was atrial fibrillation. So in the people who had a stroke, there were 9 people in that study that had a stroke from AF. Only 3 of them actually had thrombus in their atrial appendage. So we see AF, we assume that's the cause, we give them anticoagulation, but actually it might not be, it might be something else. And in a lot of cases, there was thrombus elsewhere, often the carotid. So I think, seeing the whole picture from head to toe about where stroke can be caused from. Now, obviously, you could say diaphragm and above, but for most things. But I do think that we are on the verge of actually understanding stroke better. And as I alluded to, I think for the carotid disease, most strokes occur in plaques less than 50 to 70%. And that's true in myocardial infarction, of course. Most myocardial infarctions occur on small plaques, not tight plaques. Although the tighter the plaque, the more likely you are to have thrombus on it. So there's that sort of paradox. And I do wonder whether there's some thought should be made to actually screening the carotids with a thrombus tracer. And if you've got a ruptured plaque on your carotid, you should have it out whatever the size is, because we saw from the follow-up that actually that's where all the events are, and that's where most of the events are. The small percentage, and it is a small percentage, that have a stenosis of greater than 70% have it removed. But actually, when I talk to the vascular surgeons, they often say, well, it was smooth and fibrotic, and I'm not sure it actually caused the stroke. So I think there's a real dilemma there. We've got a treatment that is effective in high-grade stenoses, but can cause strokes. And actually, if we had a better biomarker, rather than just going on stenosis, look for the cause, i.e. a clot, actually doing a carotid endarterectomy might be better for the patient, whatever the stenosis is. And if you don't have a clot, whatever the stenosis, don't give them a carotid endarterectomy. So I think that's one of them. And then the other one, of course, is the classic PFO. PFOs are present in 1 in 3 of us. So that happens if you've not had a stroke. We've all got 1 in 3 people have got a PFO, and then you have a stroke. Well, was it a PFO that caused it? And how do you tell? It's at the moment, what you do is you screen all those things that you're looking for a cause, and if you can't find it, and PFO is the only one, then you close it. But was that right? And of course, a total body PET will give you that answer. It'll give you that certainty of what's going on. And there were quite a few cases where the cause of the stroke was inferred and actually turned out to be completely wrong. The heart valves in particular, that was also fascinating. That we see on aortic and mitral valves, and looking for undiagnosed problems like that and anticoagulating those people as well for the period. But of course, is that the right thing to do? We don't know yet. So it's actually, for stroke, I think we're moving from an inference-based approach where we infer the cause based on the tests that we have and the known associations, to a mechanism. If you've got clot, where is it? And that defines your treatment. So those are the 2 big ones I think that I'm thinking about in terms of applications of this technique in the cardiovascular domain.
Excellent. Yeah, I mean, really interesting. As you say, you've discovered sort of new biological insights that you didn't even realize. Small arteries causing strokes with thrombus, more LV thrombus post-MI, etc. What about other conditions? Sudden coronary artery dissection, myocardial infarction with non-obstructive coronary. I mean, are there rare or more specific conditions that you think actually, yeah, there could be a real niche here that actually a PET scan could be useful?
So we have looked at some MNOCA to a degree, and with particularly with SCAD, so spontaneous coronary artery dissection. And as you know, for spontaneous coronary artery dissection, it's quite controversial what you should do. We try not to stent them, we try not to treat them, and then do you give dual antiplatelet therapy? So a cardiologist's mind, you've got a dissection flap, you need to make sure you anticoagulate with dual antiplatelet therapy to really stop them having a thrombotic occlusion. Others have pointed out that it's not the case, and actually do more harm by giving it, and it might make the hematoma worse. So we've done a series of about 10 people so far with spontaneous coronary dissection with this technique. And what we're finding is we don't see any GP1 uptake. And the reason I think that is because, as with often dissections, they often start off as a hematoma, an intramural hematoma. And if they don't start off that way, then they become that way when the blood gushes in. And of course, what we're looking for here is a concentration of activated platelets that are aggregating into a thrombus. And if you've got a hematoma, yes, it does clot, but that's fibrin based. It's not all the platelets coming together. So actually, you don't actually see any platelet rich clot in the spontaneous coronary artery dissection. So I actually think that is telling us that we shouldn't be giving DAPT to these people. And there is a trial ongoing now, I think, that's just been funded, that's going to look at SCAD and dual antiplatelet therapy. And based on the PET data that we have, I would predict it wouldn't make any difference or have any benefit. But that's yet to be determined. But that is an example where, is it thrombosis or is it hematoma? And what's the balance there? And actually, the GP1 is telling us it's probably just hematoma, and you shouldn't be doing it. And actually, it might make things worse by making it bleed more into it than not.
Fascinating. Yeah. And what about stopping anticoagulation? I mean, you showed that the signal declines with time, but actually there is some signal still in chronic LV thrombi. I mean, is there a scenario where you have a laminar thrombus or a thrombus that isn't active on PET and there's a high bleeding risk? And I mean, I'm just thinking of potential scenarios here. I mean, how can we use it to avoid anticoagulating patients who may be at high risk of bleeding?
Yeah, so that's, and again, great question. So I think several things to say. If you have a laminated fibrosed thrombus, it doesn't light up with a GP1 unless there's a rough area on the surface that's got activated platelets sitting on it. And we have seen some people who've just got fibrotic organized thrombus that doesn't light up. So it is fresh platelets. But as I showed you on the prosthetic, that actually sits on lots of things, and they seem to turn over and repopulate. So you can't be completely certain of that. In the LV thrombi, it was quite helpful. The study that we've done. The question then is, if you stop it, the anticoagulation, and then re-image them maybe a year or two later, does the thrombus come back again? And we don't have a clear view on that yet, because we haven't done those studies to really address it. But it is a really important question, because we historically just we see people with LV thrombi, we anticoagulate them, we do a repeat echo, sometimes an MRI, 3 to 6 months afterwards, and if it's clear, then we stop giving the anticoagulation. Well, is that too soon? Is that right? Do we need to wait longer? So these are unanswered questions, but certainly I think we do need to know the answers for that, just in terms of management, because anticoagulation is not risk-free either. And I suspect it will partly come down to the size of the infarct, the size of the akinetic segment, and all those sorts of features that will determine that. But we just don't have that data, but this technique will be able to address that question.
Yeah, perfect. I guess the other question then leads to the tracer itself, GP1. I mean, is this the best tracer? You know, there are fibrin binding tracers. There, you know, are there limitations, challenges, things you've encountered? Is there anything that you wish would be better about the tracer, or you're looking for something else, or are you happy with this?
It certainly behaves extremely well. I mean, there are fibrin tracers, as you say. The ones that I've seen, some of them copper binding. They don't give always the best image. The resolution that we're getting, you're down to millimeters with this tracer, is phenomenal, and it's given us really crisp images. And as you saw from the endocarditis case, it really does show you the power of what it can do. So we're very happy with it. I suppose the downside is it's a F18 tracer, and therefore you need a cyclotron and a production. I think there's a lot of enthusiasm for the tracer from the companies now to develop this further. I think there's also the option potentially of making a gallium tracer, which would allow you to do more infrequent ones on the day, rather than program them a certain day of the week. So I think the gallium tracers would certainly be a version of it, would be a real help to make it more accessible. And certainly the company are looking to make it more accessible.
Thank you. We also have an audience question. So Jason's cleverly covered one of the audience questions there with that previous one. But the second audience question is about the additional biological value that PET adds compared to conventional perfusion imaging using SPECT. I don't know if you've got any comments on that. So why use PET if SPECT already exists, I think is the question fundamentally.
Yeah. So obviously, I mean, that is a valid question, and it comes down to resolution to a degree, and also quantitation. Although quantitation in terms of thrombus is perhaps less important, I think. Is it there or isn't it there? You want to know the answer. It's more of a binary decision. Certainly for stroke, where's the thrombus? Where's it come from? Where is it? The uptake values, we can come up with thresholds for it in terms of diagnosis, etc. But it really is a binary yes/no sort of question. So SPECT may also be an option for this technique, absolutely. But partly for this seminar, when you're looking at the whole body with a total wide field of view, you capture all of the potential sources very nicely. So that really can help inform you in it. And also gives you an idea of what else is going on in the body, as I showed in terms of cardiovascular risk assessment, these people with PVD that are undiagnosed and are clearly quite active. But yes, SPECT, single photon, absolutely, that is a possibility. But the tracers as developed for the small, ultra small structures, I think are really very nicely detailed by the PET imaging that we have.
Thank you. Dr. Tarkin, any final reflections?
No, just to say, thank you to Professor Newby. Thank you, to you, Dr. Drew, and the NPIP for hosting the seminar.
Thank you. Professor Newby, any final reflections?
No, I think this is one example, one tracer, but as you can tell, I'm excited about it. There's potential application in some of the biggest diseases that we face in cardiovascular disease. But the beauty, of course, of PET is we can look at the whole body system, and this is one example of where looking at the whole body really makes a difference.
Thank you. Well, I'd like to conclude by thanking you both very much for your contribution to this webinar today, for providing your expert insight into this area. I'd like to thank all of the audience for joining us today and for posting the questions in the Q&A panel. And I'd like to see you all in the future webinar, which is on the 17th of March, where Professor Stephen Meikle and Professor Dale Bailey from the University of Sydney will discuss the Australian Total Body PET programme with a presentation titled Research Meets Clinical. And the registration details for that webinar are on the MPIP website. We look forward to seeing you then. Thank you very much.